Welcome everyone to today's webinar. I am Laura Dierda, Editor-in-Chief of Becker's Spine and ASC Review. We will begin today's webinar with a presentation and panel discussion, and we'll have time at the end of the hour for questions and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our esteemed panelists. We are thrilled to have Stephen Kerr, a senior analyst who leads orthopedics research divisions of the advisory board that serves strategic planners, service line directors, and business development leaders. During his time at the advisory board, he has advised numerous hospitals and health systems on service line planning, program development, investment decisions, and emerging trends within the orthopedics market. We also have Dr. Michael Thorpe, who was one of outpatient total joints' early pioneers. He opted to move his cases out of the hospital in 2005, having opened Pacific Rim Outpatient Surgery Center in Bellingham, Washington in 2003. Alongside a triple board certified anesthesiologist medical director, Dr. Thorpe developed best practices and protocols based on a review of protocols in use nationally at the time and his own experience. Today, the independent for-profit ASC is comprised of nearly 45 shareholders performing multi-specialty surgeries, including joint replacement. And finally, we have Dr. Eichmann of Cornerstone Orthopedics in Sports Medicine in Superior, Colorado. He is an orthopedic surgeon and an expert in the process of developing joint service lines in ASCs. He was named in Becker's Top 101 Physicians to Know in the ASC Industry in 2014 and founded ASC Joint and Spine in 2015 to help organizations build comprehensive programs nationwide. Dr. Eichmann has extensive contracting experience and has advised insurance companies and health systems. I am also pleased to be joined by my co-moderator today, Steve Dunn from McKesson Medical Surgical's ASC segment. McKesson helps surgery centers succeed every day with a comprehensive product portfolio ranging from anesthesia drugs and supplies to orthopedic drapes, specialty instruments, and capital equipment, as well as tools and services to help automate manual tasks so you can focus on the health of your patients and your business. At our Becker's conferences, we have seen a steady increase in the amount of interest in outpatient joint programs, and we hear from many people who are thirsty for knowledge about the still largely uncharted territory, so I'm thrilled to be part of today's discussion. Additionally, when McKesson came to Becker's with the mission of helping surgery center operators and clinicians meet the demands for joint services, we were excited to partner on this event. And speaking of McKesson, I will now turn the floor over to Steve, who is excited to speak with you all today.
Thanks, Laura. I appreciate Becker's teamwork in making today's webinar possible. And I also want to thank our guests, Dr. Eichmann and Dr. Thorpe, two highly esteemed physicians who are not only pioneers in outpatient joint services, but equally successful business operators. So we're lucky to have two guests who can provide attendees a great overview of what's worked so well for them from both a clinical and business perspective. And we're fortunate to have Steve Kerr with us today. I refer to Steve's work at the advisory board regularly as I think about how to help our customers succeed through what could rightfully be referred to as an orthopedic revolution. Steve Kerr, we all know it's exciting, but help us quantify just how big this opportunity is.
Yeah, absolutely, and great to be here with you today, Steve. As you mentioned a moment ago, we're certainly seeing a lot of change within the orthopedics market, which is having a noticeable impact on where we're seeing the most growth occur. For example, we're expecting to see a rapid shift towards outpatient orthopedic services in the coming years. And that's because volumes have been migrating to outpatient settings for many years now, but this trend is projected to accelerate over the next few years. And nationally, we're projecting outpatient volumes will grow by 22% over the next 5 years, while inpatient volumes are expected to stagnate at a little less than 1%. And then, now this trend is playing out across all specialties. In most orthopedic specialties, subspecialties, outpatient services will be the driving force between orthopedics growth in the coming years. And joint replacement in particular is one of the key contributors to this trend, since we're projecting that on a national level, all growth is going to occur in the outpatient setting. And this represents a seismic shift in how joint replacement services are being delivered. And that's because up until several years ago, most joint replacement growth occurred in the inpatient setting. Going forward, though, we're projecting that outpatient settings will be the primary growth driver in the specialty as volumes continue to move out of traditional inpatient settings.
And Steve, what are the key factors driving the growth?
So there's several factors that have been driving this outpatient shift that we've been seeing in the orthopedic specialty in general, and especially in the joint replacement space. So the first are technological advances. The number of providers that are proficient in performing minimally invasive surgical techniques has increased, which has made it possible to perform joint replacements and other higher acuity surgical procedures safely in outpatient settings. And the second is increasing disease prevalence. So we're also seeing increases in the prevalence of obesity and osteoarthritis, along with the growth of the Medicare age patient cohort as the baby boomer population ages. And now these factors are causing a rapid increase in demand for high revenue surgical services, and that is especially the case for joint replacements. And the final factor that's driving this outpatient shift is payer coverage expansion. So these payer coverage expansions have played an important role in accelerating the outpatient shift for joint replacements. Now that it's technologically possible to perform joint replacements in the outpatient setting, payers have begun expanding coverage. Now, coverage expansion started with CMS's coverage of unicompartmental knee replacements in ASC settings about 10 years ago in 2008, and gradually increased as commercial payers began covering a wider range of outpatient joint replacement procedures. And as everyone here today is probably aware of at this point, the most significant recent change has been CMS's coverage expansion of hospital outpatient joints. Looking forward, though, the next move on CMS's part will be whether they will decide to expand coverage to ASCs. Now, this is something that we're going to be monitoring closely over the coming year as CMS evaluates expansion decisions for 2019. And these trends are only expected to accelerate in the future as the aging population continues to drive up demand for surgery and payers increasingly steer volumes out of inpatient settings to control cost growth.
Thanks, Steve. You know, it really is a once-in-a-lifetime opportunity. And to help attendees today capitalize on this huge opportunity, we asked you when you registered which topics you'd like to discuss the most today. And in addition to some of the things Steve just discussed, here are some of the things that you're most curious about, so we'll be sure to cover them all. So with that, let's jump in. Dr. Thorpe, many of our attendees are asking whether it's even feasible to move services out of a hospital and into an ASC. You did exactly that over a decade ago. What's the most important advice you can give someone who's where you were back in 2005, 2006 as they're considering a move?
Well, thank you, Steve and Laura, for having me as a panelist. I guess to steal a cliche, I would say just do it. Be brave and be confident. If I kind of feel like if I can do this, and I'm not a fellowship-trained joint specialist, I'm a community general orthopedist, but I've been doing joint replacements for 30 years, and I think if you're already doing joint replacement well at a hospital and you have an ASC already, this is not a big deal. You can just transition right away. As you mentioned, we developed a multi-specialty ASC back in 2003. We have 5 big ORs, and we had 4 rooms that are designated 2359 rooms, so patients can stay overnight and be out the next day. So we already had that set up. And then in 2005, I left my hospital practice. I was doing about 400 cases a year, 200 joints a year, but with a dispute over ER call and so forth, I drew a line in the sand and walked away. I missed doing those total joints, and so I got a hold of some national protocols and with my own experience put together best patient care protocols and started doing joint placements in our surgery center in 2006, May of '06, so 12 years ago now. Started with total knees and then quickly transitioned to total hips and total shoulders. And I was the first person in the state of Washington to do this, and it was a little scary at first, but now it's it's a national trend as it's being pointed out, and I would just encourage people to jump in. We went from about 20 cases a year early on, and last year I did 67 and on target for 100 cases in our ASC this year.
Great. And you talked about the importance of assembling the right team. Tell us a little bit about how you went about that.
Well, first off, I kind of said, we got to get paid for this. So I met with the medical director at our best commercial insurer. They had a lot of lives in our area. They reimbursed us well, and I showed them our care plans and so forth so that, one, we'd get paid. Then I assembled a team from admit nurses, OR nurses, and techs, and recovery room people, as well as the overnight stay nurses, which are much better than you'd get in a hospital. Usually in the hospital at night, you've got the nurses who are most junior, lowest on the totem pole, so to speak. We have recovery room or ICU nurses spend the night with our patients. So that, and we got a physical therapist. Actually, I've done both of his knee replacements, so he's great at educating our patients. You got to get needed equipment to do these, which isn't much, and get your vendors on board, and then that's how we started.
Excellent. And Dr. Eichmann is going to go really deep on contracting, but why don't you give us your number one tip when it comes to negotiating with payers?
Talking to Dr. Thorpe?
Right.
Yeah, okay. Well, in our community of 100,000 people, we know the medical directors at our insurance companies. So I think that was the best thing I did, was sit down several meetings with that medical director, because that's your colleague. He's a doc. He understands that you're doing good things. And then I let our administrator meet with the payer people and show them that our costs were going to be significantly lower than the hospital, and I think that's the thing. Money speaks, and if you point out you're going to save them money, I think they're a lot more interested.
Right. Thanks, Dr. Thorpe. Dr. Eichmann, you have deep expertise when it comes to negotiating contracts. Tell us how you went about it.
Yeah, so for me, I decided I wanted to do outpatient joint replacement in an ASC somewhere in the vicinity of 2007 time period. And as I worked to do that, the ASC that I was working with just couldn't see a way to do it contracting-wise. They eventually went out of business, and I started with a second ASC, and it took me 2 years to do my first case after starting with with them. And so what's really important is there's a contracting cycle often that ASCs are in with the payer, and so a lot of times ASCs don't want to really open up the contract until the contract is up for renegotiation. So it's really critical to have in your contracts not either named total knee and total hip replacement, or if you have another procedure that allows you to do something like this in your center, to make sure the reimbursement is appropriate so that you can make money rather than lose money when you include the implants and costly things like this.
Okay. And speaking of being reimbursed for implants, can you give any additional insights to listeners on how to negotiate contracts that do cover the cost of implants? And what's maybe a reasonable rate to expect?
Sure. So there's a couple of different strategies. So one is to do a contract for the services of the center, and then have the implants as a separate contract. A lot of the facilities that I've worked at have had this type of arrangement. Sometimes it makes more sense to have the implants be included in your overall contract, but then the pressure is on you to try to reduce the implant cost. and you have those negotiations with an implant company. So I would say if you have good relationships with implant companies and feel that you're in a, the surgeon is willing to sort of leverage that, that including it in the overall contract is probably a good strategy. If it's not really that way, then probably having it be separate would be a better strategy.
Okay, thank you. And Dr. Thorpe, anything to add to that?
I would just say most of our contracts, the implants are covered in that the payer is giving us a percentage of billed charges, such as 70 or 80% of billed charges. There are a few that want to carve out the implants, and then I totally agree with Dr. Eichmann. You've got to lean on the implant vendors to give you a good price.
Sure. Okay. So, Dr. Eichmann, after our listeners have negotiated some great contracts, they're one step closer to making the transition. Are there any physical space requirements listeners should consider at the outset?
Yeah, I think it's important to just look at the facility, the plant overall, if it's already built, and just make sure that it's appropriate. So having appropriate, for example, air exchange, positive pressure in the OR, HEPA filters, things like this that are pretty standard, for certainly in any sort of a hospital. And in an ASC, there's more variability there. And the ASCs that I work at actually had better systems than the hospitals that I was working at. So they're very up to date, but there are ASCs that maybe were built a long time ago, for example, where this may not be the case. So it's just important to at least consider that. There's also, instrumentation considerations. When you get started, there's going to be some sort of a capital purchase often. And it really has to do with the acuity of cases that are currently going on at that ASC. If they're already doing spine cases and things like this, or bigger cases, then they're going to have a lot of the appropriate instruments that you need. If the biggest, if they're just doing carpal tunnels and very simple things, then they're not going to tend to have the type of instruments that are needed, and there's going to be bigger capital purchase involved. And then sterilization equipment is another thing to look at, like the sterilization machine, the autoclave, things like this. Seeing how many pans you can sterilize at one time. It's not uncommon for an ASC to have a sterilization machine where you can only fit 2 pans at one time, and that can make it somewhat difficult to do a large volume of joint replacements. Sterilization-wise, it can be quite onerous to get those sterilized.
Sure. And I know we got a couple questions about whether there's any sort of a rule of thumb with regard to case volume versus number of pieces of equipment and trays and so on. Any additional insights there?
I guess what I would say is I tend to work at these ASCs one day, in a given week. And so I'll come there and I'll do however many cases I'm going to do all in one day. I know that's not as ideal for the ASC, but it tends to be a typical surgeon schedule. For me, we started off, I've got two different joint replacement programs going at 2 different ASCs. The one started off with a machine that could sterilize 4 trays, and that one hasn't really been a problem. It works really, really smoothly. The other facility started off with a machine that could sterilize 2 trays. That was difficult. They needed us to bring the instruments in, days and days before the procedure so they could somehow slip them in, between sterilization loads, if you will, and get them done so they didn't have to keep people overtime to sterilize the stuff. And it was somewhat onerous. When we went, they then decided it was worth buying a machine where they could sterilize 4 trays at a time, and they've made that capital purchase, and that's been great.
Excellent. Thanks, Dr. Eichmann. So there are some good tips on how to get started. Now let's talk about some of the most important clinical aspects of a successful program. Dr. Thorpe, patient selection is obviously crucial to success in an outpatient setting. Tell us how you went about determining your criteria and what they are.
Okay, well, I think that it's important to have early success. You don't want to do things other than straightforward cases on healthy people. So be strict at the beginning. And we chose to do only ASA 1 and 2 type patients initially. I make sure that their BMI is less than 40 and that they've been medically cleared by their primary care doc or a specialist, and things like their hemoglobin A1C is under 8, and all the standard issues are taken care of. Later, after you get going, we started opening it up to stable ASA 3 type patients where they may have high blood pressure, sleep apnea, things like that, and they are stable. And I think that's the most important thing to do. And these are commercially insured patients with the total joints. They're non-Medicare, non-Medicaid type people, and the unis, we can do Medicare unis, so that opens it up to older people, but you still want to make sure they're pretty darn healthy. And then also you want to make sure they have great home support, a spouse or a partner, friends and relatives, things like that are around. I said, I don't want to know that Aunt Tilly is flying in from Florida and may or may not make the plane. You want to make sure that they've got a coach set up. And earlier on, I also said, I talked about the WIMP factor. I don't want somebody to have a high WIMP factor. But lately, with some additional things I'll talk about later, that's not even been a problem. Unless they're extremely wimpy, I really don't worry about the patient's ability to handle some discomfort and things like that.
And wimpy, that's a medical term, right?
Yes, it is.
So what works best in preparing patients for surgery, both physically and with regard to patient expectations? So how do you prep patients both emotionally and physically before they go into your center for surgery?
Okay. Well, I see all the patients myself preoperatively and evaluate them, educate them with models and so forth in the office. And then I offer a physical therapy appointment either with an outpatient therapist that they're going to see postoperatively, or most of these people are getting home health physical therapy for a few days after I discharge them. I do all my cases on Thursday at our surgery center, so they go home Friday morning under 24 hours, and I have the home physical therapist see them on Friday afternoon, Saturday, sometimes Sunday, until they can get more comfortable and get to an outpatient center the next week. So this home health service that we have 2 options here in town. They will actually do a preoperative class for the patients. They'll do a home visit and check for make sure that they don't have rugs and extension cords and things, and that their furniture is wide enough for them to get through, and also do some preoperative strength training, things like that, gait training. Some of them haven't walked with crutches or walker before, so I'll have them do that so the patients are much more confident going into it.
Great. And importantly, tell us about your pain management protocols. And get specific here. We got a lot of questions about this, as you could imagine. Okay.
Well, I use a multimodal analgesia program, which there's a lot of variables out there. Other people use different things, but I give a pre-op dose in the holding area of oxycodone, 10 milligrams, Tylenol, 1,000 milligrams, and then gabapentin. I'll give 600 milligrams if they're under 65 and 300 if they're over, and then I use 15 milligrams of meloxicam. Used to use Celebrex. These don't inhibit platelets, so that's why I choose the COX-2 inhibitors. However, a lot of people had sulfa allergies, and we couldn't use our Celebrex, so we switched to meloxicam, and it's a lot cheaper also. So I'll do that preoperatively. They have a spinal block plus sedation, only using a general if the anesthesiologist can't get a spinal block. And intraoperatively, I was going to other non-pain management things here first too. We use TXA, which is pretty standard intraoperatively, and then another gram 3 hours later. I have the anesthesiologist give dexamethasone and Zofran IV for nausea purposes. I really want to make sure they're not nauseated postoperatively. Intraoperatively, I use a liposomal bupivacaine injection. Exprol is the brand name, and I think it's so important to do that correctly. You know, a lot of people use it, say it doesn't work. If you really take the time to raise a wheel of that local anesthetic every 5 to 10 millimeters around your cut surfaces, I found a dramatic improvement in pain relief postoperatively. Also, you know, don't use drains, smaller incisions. I don't do the barbaric staple anymore. I close all my wounds with subcuticular monocryl and steri-strips, and you know, the patients and their families and their friends all see what's on the outside. They don't know what you did inside. If they see a nice, small, neat incision, and they don't have to have staples taken out in the office, I think that's kind of building your word-of-mouth referrals too.
Sure.
Yeah, postoperatively. Yeah, I was going to say postoperatively. You know, I continue the meloxicam in the perioperative time period, and when they go home, if they're already taking a leave or, you know, naproxen or ibuprofen, that's fine. I just switch over to that. I encourage them to take Tylenol, and then I'll discharge them usually with oxycodone, and then 5 days of gabapentin.
Okay, excellent. Dr. Eichmann, I'm sure listeners are eager to hear about your selection criteria as well. What have you found works best patient selection?
My patient selection criteria is actually quite similar to Dr. Thorpe's. I started off with ASA 1 and 2 and just limited it to that. And then have become a little bit more liberal. I will do sort of healthy 3s. An example, like somebody with sleep apnea that doesn't really have anything else wrong with them, would be a classic example of a 3 that I would do as an outpatient. Pretty much what I try to avoid is somebody that is at a high likelihood of needing a medical consult or a cardiology consult or something like this, because you don't have consultant access at the facility. And so somebody that's had a stent before or something like this is much more likely to have some sort of cardiac event, and so I'd prefer to do those at the hospital where I have cardiologists. Same thing with like a really brittle diabetic, somebody that's on 3 or 4 different medications, has trouble controlling their diabetes. That's somebody where I might turn to help from a medical specialist afterwards, and so I want to have them available at the hospital.
Sure, makes sense. Thanks. And I understand when you first got started, you used home health care services, but you changed your approach after a while. Tell us about that.
Yeah, so the first year I started, it sounds like very similar to what Dr. Thorpe is doing, where I kept patients 23 hours. I would have the therapist see them the same day and then round on them, the following day and discharge them. And then they went home with home health. And I think that is a good way to start off, especially if you're concerned there may be sort of gaps in your care and you're worried about people sort of getting lost to follow up or something happening to them. I realized that for me that was not necessary at the end of that year, and so I kind of, for about 6 months I did some outpatient, some 23-hour, and then I flipped it to straight outpatient. So my patients go home about 4 hours after their surgery, and have since 2013. And I do just outpatient therapy. I don't use home health. I realize that's not necessary. And so virtually every single one of my patients does outpatient therapy. Every great once in a while I'll have somebody where they'll tell me it's a big deal getting the rides into therapy for them. And so I will do home health, but it's more about transportation than anything.
Sure. And for both Dr. Eichmann and Dr. Thorpe, staying on home health for a second and understanding, Dr. Eggman, that you've gone a different direction, except for when transportation dictates. Dr. Thorpe in particular, how do you go about selecting the home health agency that you use?
Well, it depends on what the patient's insurance plan will pay for and who they have contracted with. Like I said, there's only 2 options in our community, and that covers the great majority of patients. But sometimes I'll get patients from outside of our county, and a different service goes down there. So it just depends on what's available for that patient and their insurance plan.
Sure, that makes sense. So, Steve Carrick, our listeners are ready to negotiate great contracts. They've got some great clinical insights. They know what type of facility and equipment they'll need to get started. What trends do you think will have the biggest impact on their ability to compete for patient volumes?
Yeah, thanks, Steve. I think the biggest trend that we want to keep in mind here is the trend of patient consumerism, which is playing a very significant role in how providers need to approach their referral growth strategy. So broadly speaking, the consumerism trend takes the form of patients self-referring to a specialist rather than following the traditional PCP referral pathway. And this is particularly relevant for joint replacement providers since the procedure's elective nature gives patients the time to shop for care. So since these consumerist patients are disrupting traditional referral pathways, the most important first step for adapting to the trend is to start by understanding what motivates these patients. So to do that, the advisory board surveyed over 4,000 consumers to help identify the factors that drive patient self-referral decisions. And what we found was that that word-of-mouth recommendations, price, and convenience had a significant influence on where patients decided to self-refer for care. So to give you an example, 20% of the self-referring patients in the survey indicated that family or a friend's recommendation was their top driver for selecting an orthopedic physician. And this is pushing providers to think about how to showcase the quality of their experience and to operationalize word-of-mouth referrals to attract new patients.
Okay. And so given that patient consumerism has become increasingly important, what strategies should providers implement to grow these self-referrals?
Well, a great example of how we've seen orthopedic providers tap into the growing share of word-of-mouth referrals I mentioned a moment ago are patient alumni networks. So these are generally built around former patients who've had an optimal outcome and are open to sharing their experience with potential patients. So these patient alumni, they're also known as patient ambassadors. They generally attend a provider-sponsored training session to ensure that they're messaging their treatment experience appropriately, and then they share their experience in the community with friends and family members. And this can be a very effective, low-cost method for boosting self-referrals. In fact, we recently profiled a practice that developed a patient ambassador program, and they found that their referrals went up by 50% after launching the program, which I think we can all agree is a very significant increase. So safe to say that patient self-referrals are going to need to be top of mind when developing a growth strategy in addition to those traditional PCP-driven referrals.
Sure. Thanks, Steve. Dr. Thorpe, I know in talking to you that these trends that Steve talks about ring true on the ground. Tell us what you've done to compete for patient volumes in the Bellingham area.
Well, I would emphasize also that word-of-mouth referrals are absolutely the best. And so to that, nothing outdoes doing a great job and showing the patients that you care about them. So if you've got a good patient following and do good work, they will tell their friends and family and so forth, and that's the best. After that, I educate the primary care docs, and a happy patient goes back and sees their family doc and shows them their smaller incision and no staples, and they're doing great, and they're happy. That educates the primary care docs right there. But also go ahead and go around and meet them and give talks to your primary care docs to let them know about your program. I think also educating the insurers is vitally important. As I mentioned, we sat down with one insurer, and now 12 years later, that insurer wants all of their commercial payers, commercially insured patients to be done at our surgery center rather than the hospital because of the large difference in cost. You have to be aware of the hospital lobby is very strong to these insurers, and it took a long time for us to get the Blues, the Blue Cross and Blue Shield, to come over and let us do it, because were being whispered in the ear by the hospitals. And now that it's a national trend to do this, it should be a lot easier. Our ASC took out some ads in local magazines, like a featured health article, health columns in the paper. They even put an ad on the buses here in town, had a picture of a couple of us docs and espousing the total joint program. That was interesting. Also on both the ASC website and our own group's website, we've got patient blogs on there. Facebook enthusiasts like to put blogs on there that say how great it was to have their hip or knee replacement done in a surgery center. So those are all different ways that we've got the word out.
Great. And I know you mentioned that you use we'll call it a patient portal or a patient engagement tool online that a third party provides. You see that as part of how you've created a boutique experience? To any patient feedback on the patient engagement, patient communication aspect?
Yeah, you're referring to a company called VidScripts, vidscripts.com, that we've just started using this year. And what that is videos of me answering frequently asked questions. And I give the patients a little card that tells them how to go on the internet and find this, plug my name in, and then they can pick all the different questions and items that interest them and click on it, and then I'm there talking to them. And the patients that have used that this year have just raved about it. It keeps them from calling our office as much, plugging up the phone lines and tying up my nurses and so forth. So both the patients and the nurses have really enjoyed that.
Excellent. And Laura, I believe we have a poll.
Yes, and great insights from all of our panelists and attendees today who are hoping to launch the total joint programs. We did want to do our poll and our attendees today to get a sense of the current landscape. Could you please respond, when do you plan to introduce a new total joint procedure? If you already have one underway, planning to launch one in the next 12 months or more than 12 months? You can submit your answer on the screen and then we will share the results. Excellent. So it looks like we've got around 40% of our attendees planning to launch a program within the next 12 months. 37% have already launched one, and then 23% are not planning to launch one within the next 12 months, but perhaps that's in the future. Thank you all so much for your responses. With that, I would like to thank Steve, Dr. Thorpe, and Dr. Eichmann for lending your expertise and your informative presentation. Today, we are able to cover building a foundation for total joint replacements in ASCs, payer contracting, patient selection, patient education, pain management, and how surgeons can compete in local markets. We will now begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled "Enter a question for staff" and clicking send. We may try to get through as many questions as we have time for. To begin, this is a question for Dr. Eichmann or Dr. Thorpe. Do either of you use a nurse navigator or someone who follows the patients closely preoperatively and for postoperative follow-up?
Dr. Thorpe here. I do not. I wished I had that resource, but I'm the nurse navigator. I pretty much am in charge of doing everything from front to back.
This is Dr. Eichmann. I would echo what he said. I think unless you are working in a very strange economic situation, that's very difficult to have.
Excellent. I really appreciate your insight on that. And next, we're looking a little bit into the future for physician groups that are planning to build ASCs over the next few years. Should they expect CMS total joint replacements or not? And especially in a scenario that the surgery center might take until 2020 to finish, should they build based on expecting CMS rules to change or not? And any of the panelists, do you have any thoughts or input on that?
Dr. Thorpe again. I guess my feeling on that is I initially was enthused to see total knees taken off the inpatient only list, but the more I think about it, I'm not so sure Medicare is going to pay our surgery center very well, and certainly don't pay us surgeons very well to do those, to take on the additional risk of an older patient. Some of those older patients are healthy, and I've done working people up in early 70s, and they've done fine. But when you open it up to all Medicare patients, I wonder if it's going to be economically feasible to take those on. I would rather build your program based on the commercial insured patients.
And this is Steve Kerr. Just to build off of what Dr. Thorpe just mentioned, I think it's also helpful to keep in mind that looking at Medicare, their expansion, it's only recently been expanded to the hospital outpatient setting starting this year. We're expecting that ASC expansion may be a few years before that actually happens, so a little further out in the future. I think if you look at Medicare's experience expanding coverage from the hospital outpatient department to the ASC setting for unique compartmental knee replacements, I think that's a good indicator of that this will be a little more of a gradual process. It was with uni knees, it was several years between the initial hospital outpatient coverage and that being added to the ASC payable list, which I think just goes to show us that there will be likely it'll be a few year lag before we start seeing this show up in the ASC setting.
Interesting, and thank you so much, both of you, for your insight. I think that very much covers over the next 5 years. It's hard to say what will happen, but we appreciate that. The next question is for Dr. Thorpe. How did you procure implants in the hospital setting compared to the ASC setting when you made the transition between hospitals and ASCs?
Well, I use the same implants I used at the hospital. The vendor just brings them to our surgery center, and we just had to buy some equipment to do the procedure, but the service by the vendor, my favorite vendor, is the same.
Perfect. I appreciate that. And we do have a few questions here around bundled payments. First off, I was wondering if any of the panelists would be able to touch on whether they think it would be better to do a complete bundle or a hybrid bundled payment for the facility and implants only. Do any of our panelists have any thoughts on that?
I think a complete bundle is significantly stronger. So we have a complete bundle, and we have not, probably marketed as much as we could have up to this point. But that's a lot stronger. If you could tell a patient exactly the dollar figure the whole thing is, if you tell a patient that you've got a bundle for the ASC and the implant, and then they also owe for the doctor and for all these other things, kind of defeats the purpose.
We are not doing any bundles, unfortunately, but.
Perfect. Okay. That makes sense. Thank you for your insight. The next question I have here is again about implants. When you're looking at purchasing Serum implants, do you do any of those on consignment purchasing, or how does that work?
We don't. This is Tom Eichmann. The way we do it is exactly what Dr. Thorpe sort of described. The rep shows up just like they would anywhere else. They bring the implants in for the case. You use, 4 of 90 of them that they have there, whatever it is. They take the rest home. They get a commission. Everything is exactly the same as a hospital in that regard.
Yeah, Dr. Thorpe here, that's exactly what we do too.
Perfect. It sounds like both are in agreement for those, which we appreciate. The next question is looking at, would you recommend multidisciplinary group meetings to set best practices and create the outpatient pathways? Either Dr. Thorpe or Dr. Eichmann?
Yeah, Dr. Thorpe here. multi-specialty, as in physicians, is that the question? Or just members of your team?
Yeah, I think multidisciplinary, and the different members of the team or different caretakers who are working on the case. Yeah.
Well, yeah, when I set ours up 12 years ago, our anesthesiologist medical director was triple boarded in anesthesia, intensive care, and internal medicine. That was good enough for me. So he and I sat down and determined what the care plan and the protocols would be. We did run it by a medical director of an insurance company, but that and meeting with the nursing staff and our administrator was really all that we did. We didn't bring in cardiologists, pulmonologists, and other medical specialties.
Got it. That makes a lot of sense. Then I was wondering if you could, any of the panelists, touch on what is the expected total cost of care for a total joint replacement program?
Sure. So, the facilities, I think it's going to vary a little bit by different location. Sometimes the contracting rate for a facility is the biggest variable, and that can have some variation depending on what part of the country we're talking about. I'm in the Denver area, and so in the Denver area, somewhere in the greater vicinity of $10,000 is kind of a rough number for the facility. And then there's the implant on top of that. Implants somewhere around $4,000 is common. A person can beat the implant companies up a bit and get lower than that, but that's a fairly easy negotiated rate. And then the physician fees are pretty standard, across the country. There's not a lot of variation there, so a couple of $1,000s there. And then the anesthesiologist is typically just under $1,000. And then you may want to include physical therapy or not, which is usually, depending on how many visits or whatever. And so that's basically your cost drivers right there. So you should be able to do a bundle for under $20,000 pretty easily, all in an ASC.
Excellent. And the next question I have is for Dr. Eichmann. What is the best way to staff for the 23-hour stays? Sure. So when we started off with 23-hour stay, they can't have just one nurse at the facility all by themselves. So you end up having two people, even if there's only one patient. So it's a unique situation where you have a 2-to-1 caregiver to patient ratio, which is unheard of and really great. But basically, we never had so many patients that 2 providers was not enough. I did as many as 6 cases in a day, and so 2 providers can't take care of those. But usually it was less than that, and so that was not really an issue. So basically 2 nurses was the answer. Now with the way I do it straight outpatient, there is nobody even on call that night. It's like an understanding they're going to go home, and so there's no nurse that's on duty that night.
Yeah, this is Dr. Thorpe. So I'm still doing the 2359 for the totals. The shoulder replacements and hemis, as well as the uni knees, go home. But I'm kind of an outlier in our community. I'm the only person doing outpatient joint replacements, and so I have to make sure that everything's really good. Otherwise, my colleagues that compete with me may have some ammo. So I do have 2 nurses also. You have to have at least 2, and the most I've ever done in a day that have stayed overnight was 4. So what a great nursing ratio. And I think that as I said earlier, they're ICU or recovery room level nursing people, and our patients just love it. They do it. These nurses do it on a regular basis, and I do not get calls in the night. I always call in about 10 p.m. and check on the patients. They're always doing well, it seems, and very few adjustments needed. And it sure beats when the hospital calls you in the middle of the night for a Tylenol order or something like that. So I have loved it. I'm interested in hearing about Dr. Eichmann's experience, and maybe I'll get more brave and start sending people home.
Excellent. And I have another question for you, Dr. Thorpe. Are surgical site infections an issue once the patient goes home?
Well, I've had one infection in 350 cases that I've done there, so it sure beats the hospital's data. Fortunately, it was early, and just did a washout and a poly exchange on a total knee, and he did fine, and that was actually 11 years ago. So, you know, the way I look at it is we don't have sick people in our surgery center. I would expect there's fewer germs to get a infection from, and you know, we operate quickly, and there's proper airflow and sterility, and these are healthy people. So fortunately, knock on wood, infection has not been a problem. One other thing I've said several times, my negative bias towards staples, but I remember when I did the hospital practice and we had staples in all our hips and knees, and frequently they'd come home with, or excuse me, come back to my office with little pimples around a lot of the staples. And I don't see that anymore, and I can't believe that not having a whole bunch of holes through the skin is not going to lessen your infection rate.
That makes a lot of sense. And now I have a question for both Dr. Eichmann and Dr. Thorpe. On average, how many total joints are performed per day at your facilities?
Sure. So this is Tom Eichmann. I would say, I assume the question is how many joint replacements are averagely performed when we do joints. Is that correct?
Yeah, total joints. Mm-hmm.
Okay. Yeah, so it really varies. I've done as few as one in a day, and I've done as many. I've not done more than 6 in a day at the center. I would say probably an average day is 3 or 4 for me at the center.
Yeah, and Dr. Thorpe here, 1 is the least, and 4 has been my most. That's because we only have 4 rooms to keep them overnight, and so, but a typical week is 2 or 3.
Perfect. I think that's really very helpful from both of you. And then we also have a question. One of our attendees is wondering what kind of risk stratification tools or protocols you use.
Well, I think both Dr. Eichmann and I said we're doing ASA 1, 2, and stable 3s. I don't want anybody that's unhealthy that I predict it's possible they may have to be admitted. You know, they keep stats on those kind of things, like how many admissions you have from your surgery center, and I don't want to damage those stats. And I think it's, if you have somebody that's touch and go on whether they're going to have to be hospitalized, you might as well just do them at the hospital.
I would agree with Tom Eichmann.
Yeah. Perfect. And then I think we also have a few different questions here about technology such as robotics. Dr. Eichmann or Dr. Thorpe, have either of you considered those? What are your thoughts on robotic technology for total joint replacements?
Go ahead, Tom.
Sure, this is Tom Eichmann. So, no, I was a consultant for a computer-assisted surgery company, and through that process became sort of disenfranchised with it. The only patients I've had complain about malalignment have had a computer involved. And so I have a bias against that. That's also sort of bled over into robotics. So each year I look at robotics, and what I see is mostly an opportunity for marketing and very little what I consider to be real value. And so I certainly haven't asked my ASC to spend the $1 million or whatever it is for the robot. I think that doesn't make a lot of sense.
Yeah, Dr. Thorpe here. I have no experience with robotics. A variation of that I've become interested in recently, and that's the Conformis company that takes a CT scan of my knee replacement patients from hip to ankle and uses proprietary software to 3D print jigs that have the cuts in those jigs so that the cuts and the implants will be positioned appropriately in space, and also the implants are made to perfectly fit their bones. And I've done just 3 of those so far at our surgery center because the total knee patient had deformity of their femur or retained hardware like IM rods or distal buttress plates that would require a more extensive operation to take those out so that the IM rod could be placed in the femur. And so rather than do that, I had this conformist company make the implants and make the jigs for me, and that was beautiful. It worked out very well, and the x-rays do have the tibias nicely within 3 degrees of varus or valgus, and it did not cost us or the patient any more. In fact, the cost of the implants was less than what I'm using regularly. So that's of interest. I kind of think of that as robotics before the operating room.
Excellent. And Steve, do you have any perspective from an industry-wide perspective, I guess, when looking at robotics? Any thoughts on whether they'll become more common in the future?
We've certainly been seeing the number of providers that have been using robotic systems grow pretty steadily over the past few years, both hospital-based providers and ASC-based providers. But there's still an ongoing debate within the specialty. I think that that's reflected in Dr. Thorpe and Dr. Eichmann's comments. There's some physicians that are very great proponents of the robotics technology, and there's a equally large camp of physicians that are that don't see the value in the technology. So it's a national trend. We are seeing more providers adopt it, but that is the jury is still out on whether that's the best practice or not.
Thanks for your insights there, Steve. We have time for one more question touching on readmission rates. I was wondering if Dr. Thorpe and Dr. Eichmann, if you'd be able to give a little bit of insight onto the readmissions that you've seen and some of the biggest reasons why patients might be readmitted.
Okay, Dr. Thorpe here. I've had 1 readmission in the last 2 years, and that was, speaking of my WIMP factor, it was probably, had a lot to do with it. Just the person was nervous, kind of trembling the next morning, and we just didn't feel like we could send him home. So he spent 1 night in the hospital. Prior to that, it had been years before we had admitted anybody. And early on, some things I've learned is I was giving OxyContin preoperatively and postoperatively. Quit that because of a couple patients being narcotized, and had to admit them to let that wear off. So that was a big deal. And then every once in a while you'll be surprised with some medical problem that you didn't even know about, even though I and the patient's primary care or specialist had cleared the patient. I had one person with a patent foramen ovale, and postoperatively she had a minor stroke, had to be admitted. So every once in a while things will happen that you weren't aware of.
This is Tom Eichmann. I have had a couple of readmissions, and so it's very small percentage, under 1%, but they tend to be surgical complications for me, and more often than not, I'm going to end up reoperating on them for whatever sort of complication they have.
Thank you so much to our wonderful panelists today. We really appreciate you being here, Steve, Mike, Dr. Thorpe, and Dr. Eichmann. And thank you so much, Steve, as well, for moderating our discussion. We really appreciate your time here, and thank you all for attending. We invite you to attend future Becker's webinars as well. Have a great afternoon.